everyone. Good afternoon. So I am an HPV vaccine researcher. I've been working on this since the vaccine was approved for girls in 2006. So, wow, we're going on 20 years. It has been my passion to prevent all of these issues that we're going to talk about today. But we've had some really exciting new opportunities that I'm going to get into. Some disclosures. I have a few grants from Merck. They fund the vaccine. But cervical cancer is preventable and curable. So for those of you working on different disease issues like obesity, complicated. You probably won't see the end of it in your lifetime. We are on a path where we can see the end of cervical cancer in our lifetime. And that is amazing because we have the tools to prevent it. The World Health Organization has embraced this. This was probably about 4 years ago, where they developed a global strategy for the elimination of cervical cancer. Now, how can we do this on the world level? It's vaccinating girls before age 15. It's getting women screened with a high-performance HPV test by age 35, and then one more time by age 45. And then it's treating dysplasia and those precancers before they end up with cervical cancer, but it's also treating women with cervical cancer. So in the US, despite having these tools, and we've had these tools for quite a while, we've had PAP testing since the 50s and 60s, HPV vaccine now almost 20 years, we still have 14,000 cases of cervical cancer each year, 4,000 deaths. All of these are preventable. This isn't capturing the millions of abnormal PAP test results that we have. So we were just talking about cost in the last lecture. There's a lot of costs associated with those millions of abnormal PAP tests and positive HPV tests in terms of socio and emotional, along with actual fiscal costs related to interacting with the healthcare system around those results to get the follow-up treatment that's necessary. So these guidelines have been put into effect with some minor revisions for quite a while. Women, when I first started this work, it was trying to get women away from the annual PAP test, right? Like, can we get women to start thinking about when we incorporate our understanding of human papillomavirus and how long it takes to develop into cancer, we can spread out that screening for every 3 years with a PAP test, age 21 to 65, or every 5 years with primary HPV, which has been a little slow to be adopted in the US for a lot of different reasons, or the co-testing, which is mostly what we've been doing, I'd say the last five years or so. We'll hear more from Dr. Maurer. But then just last August, we got FDA approval for HPV self-collection. And this is a game changer because when you think about the women who are most likely to be diagnosed with cervical cancer, half of them are overdue for screening or have not had screening. And there's a lot of barriers for why women and persons with the cervix aren't comfortable with screening. It's, you're exposed. It's a pelvic exam. Often I work a lot in rural settings. Women aren't comfortable with male providers and a pelvic exam, especially male providers who they are their neighbors or they go to church with them and they're talking about something that's really personal. In rural Utah, I'm working with 3 clinics right now in HPV self-collection. Less than half of the women are up to date with cervical cancer screening among these patient populations. And Utah was state number 49 for up to date with cervical cancer screening in the last year of data collected. So there's a lot of barriers around why this isn't happening. And then even when women are diagnosed and need to come back for a follow-up, many of them aren't able to prioritize that for themselves. We have large family sizes here, and I'm still determined to do that study on the correlation between family size and women taking care of themselves. And we already know the answer, but I'm still gonna do it. So we have had the opportunity to join the National Cancer Institute's SHIP trial, Dr. Maurer and myself. So we are one of a few sites, I think it's like 20 sites in the US. This is our team who's running our SHIP trial. The SHIP trial is part of the National Cancer Institute's Last Mile Initiative. It stands for Self Collection for HPV Testing to Improve Cervical Cancer Prevention. It's the last mile that we're trying to get through before we are able to really successfully embrace this as an option. Even though we already know it works, we still have to dot our I's and cross our T's. So it's the components of the trial involve assessing the usability and acceptability of the devices, looking at the accuracy of self-collection compared to physician-collected and colposcopy results, and then looking at the effectiveness of this opportunity for high-burden populations like rural populations. Another statistic that I didn't give to you, that in Utah, we have much higher rates of mortality among rural women with cervical cancer than urban women. And you could see that because to be treated for cervical cancer, you need to see a gynonc. And we don't have, maybe Kate can tell more. There's, and it's so Huntsman serves the 5-state Mountain West region. It's a lot of travel time to get to a gynonc at Huntsman. So these are the sites for the SHIP trial, and look at Utah. Wow, we're really covering the whole West. So Huntsman Cancer Institute right now, we're serving 18% of the landmass of the United States. So that's why we're embracing a focus of distance as a disparity and addressing rural challenges to access to gynonc care, prevention, and screening. So I'm going to turn it over to Dr. Maurer.
Thanks, Deanna. That was awesome, and thanks everyone for inviting me. I'm going to talk just a little bit about the SHIP trial so people understand kind of how these trials are done, but then even take a step back to show that we actually already have this data, but we're doing it for the FDA. So this is currently open if you work or go to any of these clinics. This is where we are enrolling patients. It's really straightforward. So we're trying to grasp the HPV positive population, right? That's how we're going to get a sensitivity and specificity on this test. So it's for patients who are going in for a colposcopy or LEEP procedure that has been indicated by their pre-testing, whether it be HPV or most patients a co-test, and they have to be 25. Always interesting our exclusion criteria when we're looking at women's health, so they cannot be pregnant or have given birth, and that will probably affect the indications for this self-HPV in the future. And then they can't have been treated in the last 12 months. Basically, that's it. They have to be able to actually do the self-collection. It's really simple. So really, we just ask the patient if they're willing to participate. They consent. They go into a bathroom. They do the self-collection based off of a picture and minimal instructions, because obviously that is the goal, is that this is not something that requires a lot of education around successfully completing. And then they get their clinician collected sample right at the start of their procedure, which they are already there for a pelvic exam. And we give them $40 for a token of appreciation. They're really done as soon as they start, and we've had great uptake. So this is looking as of this week, and it is hard for you to see, but we are one of the high bars. Oh, I don't have a pointer, of that like dark blue-green color. So I think we have put a lot of patients on trial already. So the SHIP is great for Utah. It's great for the Intermountain West, but we actually have a lot of this data already, so I apologize that it's a little bit small. The graphic there is actually from Australia's Department of Health, because this is part of routine screening in Australia, the Netherlands, a handful of other countries. You can actually just choose to do self-collection. But Phil Castle and his team are really the ones who have led a lot of this work, and this is their meta-analysis. So, maybe I can get the button. Nope, wrong button. Okay. So, right, we care about a screening test that is sensitive, right? You don't want to miss the false negatives. So our perfect screening test would live up here because it would be highly sensitive, highly specific. we are okay losing specificity. We're always going to lose specificity. People are going to be HPV positive, and they are not going to have what we care about, which are those high-risk dysplasias. So that's the gold standard we're looking for here. But what I want people to look at is just the purple and the yellow. So purple is a self-sample, and yellow is a clinician sample. So we are highly sensitive, and we are not that different from a clinician-collected specimen. And this is based on like 80 trials in this meta-analysis. So we've had this data for a long time. None of this is new. Ooh, sensitive. Again, hard to read, but this is a forest plot. So we know it works, and then do patients like it, right? We all know patients are gonna like it. They do like it. They're actually 2 times more likely to uptake cervical cancer screening if they're offered self-collection over physician-collected or clinician-collected. And this is based on like 500,000 women in low, middle, and high-income countries all along that forest plot. This brings us to the new exciting update. So Deanna showed this in a simpler form of what are our current like today guidelines. And so this was up until 2024 because in December of 2024, US Preventative Task Force put out a new guideline. So this is today recommendations, and American Cancer Society is a little bit different. They actually have preferred the primary HPV test since 2020. ACOG, SGO, which are a lot of the professional societies clinicians are going to follow, have always done what the US Preventative Task Force has said. But December 10th, they came out with their revised update. It was open for public review until January. It's now closed for public review, and we're all just sitting around waiting with bated breath. No, only some of us, for it to come out, because they actually also have now preferred primary HPV testing, but they've added patient collected as a preferred option. So we are anticipating that this will be the final recommendation and that ACOG, ASCP, other guidelines will take this up. That will, of course, affect insurance reimbursement and the whole pathway of getting patients self-collection as an option. Also hot off the presses, so the problem is we said we could do it. We have FDA-approved tests, and then all the clinicians are sitting there saying, well, we don't know what to do with the results because there weren't management guidelines in terms of, okay, what do we do now? So this, I think this was published around around February, but this was actually published in April. A lot of management of cervix cancer screening has come down to these risk categories, so it's gotten very complicated. There's an app for it, and you really need the app to ever decide what to do to any individual patient. But the idea is that self-collected is actually in this. This is the enduring consensus cervical management guidelines. And so self-collected is in all of these in terms of when they need their next test, in terms of who goes straight to colposcopy, which is an option, versus who needs that intermediate pap smear. This looks really complicated, but then you remember that 90% of women are going to test negative. So you're going to take 90% of women out of our clinics to even begin with for 3 years. And so we can manage this for the other 7%. And some are going to go straight to colposcopy. What about today? What can you do? You can actually order a self-collect in ARUP. Who knows if insurance is going to cover it, but it is a test. So it became available actually a couple weeks ago. This approval is important. All of this is talking about in a clinical environment. So none of this is talking about at home. That's also been very highly studied. There's mail-in options in other countries. But this is all talking about you walked into a clinic and you did your self-collect. But excitingly, our mobile screening unit counts as a clinic. And so this is, thanks to Lynette Phillips and Deanna and a lot of people at HCI, something that we are hoping to get on the bus, the mobile screening unit, possibly as soon as July, and possibly with some Utah true like funding through the CDC for our underserved, underscreened population. So you can go in, you can get your mammogram, you can take your Cologuard test home, and you can hopefully do your self-collect on the bus. this kind of, I think, I don't know if Deanna has anything else to say about this, but these are all the things we're waiting on in terms of self-collection being the standard of care or something we can offer to our patients. But it is still obviously an area where a lot more research could be done. Varner was here, he stepped out, but when I was interviewing for jobs, came out and spoke on my fellowship research project, which was actually using cards instead of liquid media. And small adjustments like this could really, because now we're using liquid media, that's heavy, that has to be refrigerated. And so there's a whole kind of domino effect for rural populations, for low and middle income countries in terms of self-collect HPV. It works, we just have to bring it to people. And that's all I have.
Questions? What about, I know this is, maybe I shouldn't mention this word, but what about vaccines?
Well, that's Deanna. I mean, obviously you can't give a talk about this without just saying the vaccine works and you should get it, but we're 40.
We're doing better.
Yeah.
We're 35.
We're 35.
Yeah.
Mostly thanks to Deanna.
I mean, there's some questions back here. Please.
Thank you, great talk. And I've been in this for a long time, but just can't seem to get our labs anywhere I work signing on to do this. Do you?
So the question is, are labs signing on to, okay.
That was mine. That was
mine.
Okay.
The question is, my understanding of the self-swab is that the lab is supposed to do the reflex cytology.
No reflex cytology. So that's not FDA approved. And so that's why if we go back a couple slides, so the question was, does the lab then do reflex cytology? And no, so they would have to come, so this middle group is coming in to get their cytology. The top group, which is 16 and 18 positive, are going straight to colpo. It's still recommended that you collect a pap at that time for atypical glandular cells or things that would require different follow-up. Also looking for discordance. So if you have an H-cell pap but your colpo shows low-grade disease, you're discordant and you need closer follow-up. But you cannot reliably send cytology off this swab. And yeah, good question.
And there's one way.
Sarah?
No, so we don't have the guidelines. Yeah, the question was, is the screening interval going to be the same? So when you actually look at this paper, they're recommending 3 years for a self-collected specimen. It's 5 for a clinician. That's controversial. It was due to a few studies showing like 2 to 4 points less sensitivity. And just not having that long-term follow-up data. So we have pretty good long-term follow-up data on the clinician-collected swab that allows us to leave it at 5. Even though the one-time sensitivity seems to be the same, what this paper is saying, and probably, I don't know what the final guidelines will say, is that we're going to start with 3 and then potentially increase it to 5.
So I just want to say a couple things. First, really exciting news. The CDC's breast and cervical cancer screening program is covering self-collect as part of their program. And that was just announced about a month ago. And it's going to really affect opportunities for low-income women, uninsured women all across the United States. So they'll be able to get this as an option and it will be fully covered. The other point was the community health centers I've been working with. I've already done 100 samples, and we've had to work with University of Washington to have the samples assessed because ARUP just came on board recently. But they've been able to be covered by insurance because the billing code is the same for primary HPV as for self-collect. So they're getting insurance coverage for it. So that's really exciting. But the Medicaid reimbursement is lower in Utah than it is in other states, which is perplexing to me. And the last comment about HPV vaccine is HPV vaccination is the first line of defense. It's the primary mode of prevention. And it's not just cervical cancer, but there's 5 other HPV-related cancers. And the most common is HPV oral pharyngeal in men, white men in particular. So I'm just urging everyone to support this vaccine starting at age 9 for boys and girls.